Welcome to the Deep Dive. We're here to break down complex research into insights you can actually use. If you're going through in vitro fertilization, you already know it's a journey. And sometimes the biggest challenge isn't about eggs or sperm quality. It can be something much more subtle, something inside your own immune system. So our mission today is simple. We want you, our listener, to come away really understanding how autoimmune factors can impact IVF success. And maybe more importantly, how today's fertility clinics are tackling these issues head on with personalized treatments. They're finding ways to overcome these immune hurdles.
It's such a crucial area, often missed in initial discussions. Your immune system, its main job is protection, right? Attacking anything foreign. But think about pregnancy. Suddenly, it has this incredibly delicate balancing act to perform. It needs to stay alert for infections, sure, but it also has to accept the embryo, which, let's face it, is biologically half foreign from the father. When that balance gets thrown off, when the system becomes too aggressive or confused, that's when we see problems, things like implantation failure or, sadly, recurrent miscarriage.
That's fascinating, the body's own defense becoming an obstacle. Okay, let's really unpack this. Let's dive into the specific culprits we found in the sources. What's really going on here?
Well, the core issue comes down to what an autoimmune disorder actually is. It's when the immune system mistakenly identifies the body's own healthy tissues as threats and attacks them. In fertility, this can play out in a few ways. It might cause chronic inflammation, like in the uterine lining, can lead to blood clotting problems, or sometimes immune cells might directly target reproductive cells, or even the early embryo.
And it seems like this isn't just a concern for people who already know they have something like lupus or rheumatoid arthritis. The sources pointed out that doctors often look into immune factors even when someone seems perfectly healthy otherwise, but they're facing specific fertility struggles.
Oh, absolutely. There are definite red flags, clinical situations that really make us think, okay, let's investigate the immune side.
Oh.
Top of the list, recurrent implantation failure, or RIF. This means someone's had multiple IVF cycles, transferred good quality embryos, but they just haven't implanted successfully. Then there's recurrent pregnancy loss, experiencing multiple miscarriages. And third, yes, a known autoimmune disease is a clear indicator. And it's worth remembering, conditions like RA or lupus aren't just about joints or skin. They can directly affect the ovaries, sometimes impacting ovarian reserve or function. There's even a condition called autoimmune ovaritis that can complicate things right from the egg retrieval stage.
So fundamentally, this immune mix-up stops the embryo from getting what it needs, either by direct rejection or by messing with the blood supply.
That's a great way to put it. It boils down to inflammation and circulation issues. Immune problems can seriously reduce blood flow, which is absolutely essential for implantation and placental development. They can also create this really inflamed environment in the uterine lining, the endometrium, making it hostile to an implanting embryo. Or, in some cases, the immune system basically treats the embryo like a foreign invader and actively tries to eliminate it.
Right. Which logically leads us to testing. If someone falls into one of these risk groups, the clinic runs specialized tests. So what are the key things they're actually looking for? What evidence helps build that treatment plan?
Okay, so in these more complex cases, we often zero in on what I call the big three markers. First up is the anti-nuclear antibody test, or ANA. A positive ANA can signal a general tendency towards autoimmunity. Think conditions like lupus. It suggests the body's making antibodies against its own cells' nuclei. A strong positive result definitely raises concerns about implantation.
But the sources were careful to mention that a low positive ANA isn't always a major issue on its own, right? That adds a layer of complexity.
Precisely. You can see a low positive ANA in healthy people sometimes, maybe after an infection or something temporary. So it's more like an initial flag. It tells the clinic, okay, maybe dig a bit deeper here. It usually prompts more specific antibody tests before anyone jumps to conclusions or changes treatment. The second marker, or rather group of markers, this is where we often find significant risk, antiphospholipid antibodies, APA, and lupus anticoagulant, LA. These are particularly concerning in fertility because they directly target phospholipids, key components of cell membranes. This attack causes two main problems: abnormal blood clotting and inflammation, specifically in those tiny, crucial uterine blood vessels. When these antibodies are present at significant levels, the risk of recurrent miscarriage and problems with the placenta goes way up.
And this is where that specific testing rule comes in, the one you mentioned earlier. The sources really stress the importance of retesting these after 12 weeks. Why is that gap so critical for confirming antiphospholipid syndrome, or APS?
That 12-week interval is non-negotiable for a solid diagnosis. Why? Because APA levels can spike temporarily, maybe due to an infection or even certain medications. The body might just produce them for a short time. So if you find them at moderate or high levels, you must wait at least 12 weeks, 3 full months, and test again, if they're still elevated. That confirms persistent chronic autoimmune issue that needs treatment. If you treat based on a single temporary result, you might be giving unnecessary medication. But if you miss a chronic risk because you didn't retest, the patient could face more losses. Verifying that persistence is everything for distinguishing a temporary blip from true APS.
Wow, okay. That really underscores how precise the diagnostic process needs to be. And the third key marker often investigated, especially with implantation failure.
That would be natural killer cells, or NK cells. These are part of our innate immune system, the rapid responders. They're designed to quickly take out infected or abnormal cells. Now, in the uterus, NK cells actually play a helpful role in early pregnancy, helping remodel blood vessels. But if they become overactive, or if there are just too many of them, they can sometimes misidentify the embryo as a threat. They might attack it directly or create an inflammatory environment that prevents implantation. And a key point about testing here, most specialists feel that uterine NK cell testing is more relevant. This involves taking a small biopsy from the uterine lining itself, usually timed around when implantation would naturally occur. Testing NK cells in the peripheral blood, just from a regular blood draw, is generally seen as less directly informative about what's happening right there in the endometrium where the embryo needs to attach.
Makes sense. And we absolutely have to talk about the thyroid connection here. Thyroid antibodies seem to pop up a lot in fertility discussions.
They really do. We need to mention anti-TPO and anti-TG antibodies. These are markers for autoimmune thyroid diseases like Hashimoto's or Graves'. What's really striking is that even if a patient's actual thyroid hormone levels, their TSH, their free T4, are completely normal, just the presence of these antibodies is linked to a higher risk of miscarriage and implantation failure. It signals an underlying autoimmune process is active, even if it hasn't fully progressed to hypothyroidism or hyperthyroidism yet. So it definitely requires close monitoring during IVF.
Okay. Before we get to the really hopeful part, the treatments, maybe just a quick word on the male partner. Do they typically undergo immunological screening?
It's not routine, no. But in certain situations like persistent RIF where other factors are ruled out, or if the male partner has significant sperm abnormalities, then yes, some specialized screening might be done. The main thing looked for in men is anti-sperm antibodies, ASAs. This is where the man's own immune system actually attacks his sperm, which can affect motility or the sperm's ability to fertilize an egg.
Got it. Okay, this is the point where things shift. For someone who's maybe been told for years they have unexplained infertility, getting a positive result on one of these tests must feel almost like a relief. Like finally there's a reason, something concrete. So once you have these findings confirmed, what happens next? What are the specific, targeted ways clinics manage these immune issues to boost the chances of success?
That sense of relief is very real for many patients. And yes, the great news is, once we know what we're dealing with, the treatment becomes highly targeted. So if the diagnosis is a clotting disorder like APS, confirmed by those persistent antibodies, then anticoagulant therapy is essential. This usually involves low-dose aspirin, which makes platelets less sticky. And often, injectable blood thinners are added, like heparin or low molecular weight heparin, such as Clexane. The goal here is to improve blood flow to the uterus and the developing placenta, preventing those damaging microclots and reducing inflammation.
So the blood thinners are basically clearing the path, making sure the embryo gets all the nutrients and oxygen it needs through good blood flow.
It's exactly right. It's all about optimizing that vascular support. Now, if the main issue seems to be more about general immune overactivity, perhaps high NK cell levels, or what we call an imbalanced Th1-Th2 ratio, then we look at immunomodulatory therapies.
Okay, hold on. Th1, Th2 ratio. Can you give us the quick version of what that balance means?
Sure. Think of your immune response having two main branches, the squads. Th1 is like the attack squad. It's pro-inflammatory, aggressive, really good at fighting viruses and rejecting things it sees as foreign. Th2 is more the tolerant squad. It leans towards antibody production and is crucial for accepting the pregnancy. In many autoimmune situations, especially related to pregnancy loss, the Th1 response is too strong, too dominant. So the goal of treatment is to kind of dampen down that aggressive Th1 activity and encourage more of the tolerant Th2 response. To do that, sometimes short courses of steroids like prednisone are used. They have a broad anti-inflammatory effect. For potentially more targeted effects, especially related to NK cells, other treatments might be considered. Things like intralipid infusions or maybe IVIE, which is intravenous immunoglobulin.
Interesting. How do those specialized treatments like intralipids or IVIG actually work? Do they sort of distract the immune system?
That's actually a pretty good way to think about it.
Yeah.
They act almost like decoys or help reset the system temporarily. Intralipids are essentially emulsions of soybean oil and egg fats. The thinking is they might help calm down those overactive NK cells. IVIG is a bit different. It's made from pooled antibodies from thousands of donors. It's thought to work in several ways, perhaps by blocking harmful antibodies or occupying receptors on immune cells, effectively reducing the attack on the embryo. Both aim to nudge that immune balance back towards the Th2 tolerance side needed for pregnancy.
And tying into these immune treatments, the sources really emphasize a specific IVF protocol adjustment, the freeze-all strategy. Why is freezing all the embryos often recommended for patients with autoimmune factors?
It really comes down to timing and creating the best possible environment. If we know a patient has an active immune issue, their uterus might be inflamed or just not ideally receptive during the stimulation cycle itself. So doing a freeze-all means we collect the eggs, create the embryos, and then freeze all the viable ones. This buys us time. The patient can then have a break, often 1 to 3 months, to let their body recover from stimulation and, crucially, to start the immune-modulating treatments, the heparin, the prednisone, whatever is needed. We let those medications work, let the inflammation settle down before we transfer an embryo back in a subsequent frozen embryo transfer or finial-T cycle. This allows us to transfer the embryo into a much more receptive, controlled, and hopefully calmer uterine environment. The success rates for FITs in these cases are often significantly better than trying a fresh transfer amidst immune system activation.
It really sounds like a multi-layered, highly personalized approach then. The immune testing results are just one piece of a much bigger puzzle the clinic is solving.
Absolutely. It's never just about one test result in isolation. A good fertility specialist integrates everything. They look at the immune findings, yes, but also the patient's hormonal balance, the quality of the embryos, sometimes using PGT, pre-implantation genetic testing to check for chromosomal normality at, and importantly, the condition and receptivity of the uterine lining itself. Sometimes tests like the ERA, the endometrial receptivity array, are used to pinpoint the exact best timing for transfer. All these pieces of data come together to build that unique, bespoke treatment plan. The strategy is always to identify and address the biggest obstacles first to give the best chance for success.
Which brings us right back to our main point for you, the listener. What this deep dive really shows is that while the immune system adds complexity to IVF, understanding your specific immune profile can transform an unexplained struggle into something manageable, something addressable. Modern personalized IVF means even conditions that sound daunting, like diagnosed autoimmune disorders, can often be successfully managed with the right targeted approach. There's real reason for optimism.
And maybe one final thought to leave you with, something quite provocative perhaps. Your immune system isn't static. It's not fixed. It shifts and changes constantly. Things like stress, hormonal fluctuations, even just getting older. There's a concept called immunosenescence, where the immune system changes with age. All these factors can influence it. What does that mean? It means ongoing monitoring and sometimes even retesting immune markers during the fertility journey isn't a sign that something's wrong. It's actually part of the commitment to finding and maintaining that perfect window, that ideal, tolerant environment for pregnancy to succeed. It's dynamic.
That's a powerful perspective. We really hope this deep dive has brought some clarity and definitely some optimism to navigating this complex world where immunity meets fertility treatment.
And now, it's really crucial we add this important medical disclaimer. Please remember, everything we've discussed here today is purely for educational and informational purposes. It is absolutely not intended as medical advice. You should always, always consult directly with your own fertility specialist or healthcare provider for any diagnosis, treatment plans, or personalized medical guidance.
And if you are looking for more comprehensive information on the entire process of in vitro fertilization, you can find a wealth of resources over at the portal ivfforme.com. That's IVFEM4ME.com.